All right, let's break this down from our case yesterday of a 45-year-old man coming into the office with elevated bilirubin. The key here is he had isolated persistent mild bilirubin elevation with other normal labs. First step is you want to fractionate the bilirubin into direct and indirect because that determines the rest of the workup. If this is indirect or unconjugated bilirubinemia, which it usually is, now you were thinking increased bilirubin production from hemolysis or decreased conjugation in the liver. The next thing to check is our hemolysis workup. So we want to check our reticulocyte count, our LDH, haptoglobin, and peripheral smear. Now, if this were hemolysis, you would expect a high reticulocyte count, high LDH, low haptoglobin. In this case, everything is normal. So now let's go through the differential. Could this be G6PD deficiency? Somebody commented that on our case. Now, this is unlikely. In G6PD deficiency, you have episodes of hemolysis that are usually triggered by infection, certain medication, or oxidative stress. You would expect anemia, abnormal hemolysis labs, and often symptoms in patients that are presenting with G6PD. This patient is completely stable and does not show a hemolysis pattern at all. What about iron deficiency? You will usually expect a low hemoglobin, a low MCV, and a low MCH on your CBC. Now, our CBC is normal, so that does not fit iron deficiency. Now, we've talked a little bit on here about ferritin. Does ferritin help in this case? Ferritin doesn't help here because this isn't an iron problem. We're really dealing with a bilirubin conjugation problem. What about liver injury? That will usually cause elevated AST and ALT, and those are normal here. Then we want to talk about, is this a biliary obstruction? That will usually cause elevated direct bilirubin, which is conjugated bilirubin. And your alkaline phosphatase, in most cases, there will also be elevated. It may also come with symptoms, and that's not what the patient was experiencing here. Now, do we need imaging? Not in this case, because our workup really is going towards unconjugated bilirubin, and we haven't found anything abnormal to point us towards imaging. So if you look at our differential, we don't have hemolytic anemia. We're not having any medication-related issues because he's not on any medication. And then we're also not having any occult liver disease. What we really have when we wrote out everything is Gilbert syndrome. Now, Gilbert syndrome is a benign condition that's caused by reduced activity of the enzyme that's responsible for bilirubin conjugation. This leads to mild unconjugated hyperbilirubinemia that's typically less than 3 with otherwise normal labs. Gilbert syndrome usually has common triggers for that bilirubin to rise, and that it means if the person got the blood work when they were fasting, an acute illness, stress, really intense exercise. So let me know your thoughts on this case, if there's anything else that I should have included in our workup or we should include in our differential, and then join us next week for our next case.